Okay.
Thank you so much, Shell. And let me just quickly share my screen. I hope it is visible.
Yes, it is.
Okay. So without further delay, as Shell said, let me go to the presentation. And just to put things in perspective, let me just, seems to be. Yeah, I'll just start with a case illustration, put things in verse. So this was a 55-year-old lady who came to us with a complaint of sudden decrease in vision in the left eye and metamorphopsia since 15 days. It was painless but progressive. She was a known case of diabetes mellitus type 2 and fluctuating control, and there was nothing positive in the family history apart from her mother having undergone cataract surgery. The anterior segment examination was quite okay, except for the presence of grade 2 nuclear cataract. So she had been diagnosed as having diabetic macular edema elsewhere and had been started on topical Nepafenec drops and had been advised anti-VEGF injections. So this is what the picture looked like. So, if we look at the clinical photo, there are obvious exudates here, but then there are also areas which, of what appears to be choroiditis, and they seem to be scattered all around the posterior pole. The OCT confirms the presence of subretinal fluid and some intraretinal thickening. And this is what the angiography looked like. So we have the classic early hypofluorescence followed by the late hyperfluorescence here. So based on a diagnosis of multifocal choroiditis, this is just a blown up image of the temporal quadrant. We advised immunosuppressive therapy, but because of her diabetic status, we advised her against steroids. And we gave her a local injection of the dexamethasone implant, or Ozurdex as it's called, and with great results. There was a recurrence about 6 months later, and she received a second injection. And ultimately, this patient was scheduled for cataract surgery, and she underwent uneventful cataract surgery with a third injection as prophylaxis. So this patient was part of our clinical trial, which compared the dexamethasone implant to systemic steroids. And as we know, uveitic cataracts are a technical challenge. And apart from the usual anterior segment issues, such as, say, posterior synechia, poorly dilating pupils, fibrotic capsules, there are also associated retinal complications, cystoid macular edema, epiretinal membrane formation, recurrent uveitis, and so on and so forth. So this is what we managed to publish about 5 years ago. And on similar lines, we also published on the role of the dexamethasone implant in Irvine-Gass syndrome, which is along the same spectrum. So, our calculations were based upon a 10% difference between the two groups. That is, one group that received systemic steroids and one group that received the dexamethasone implant without systemic steroids. So this was our purpose, to compare the safety and efficacy of intravitreal dexamethasone implant with systemic steroids as prophylaxis with cataracts secondary to or associated with intermediate or posterior uveitis. So we did not study anterior uveitis in this particular study. This trial was sponsored in its entirety by Allergan. And coming to the demographic characteristics of the patients, as you can see, the instances of intermediate and posterior uveitis were more or less evenly distributed. So the change in visual acuity and the change in subfield thickness was more or less similar for both groups. And essentially what we were trying to show is that the dexamethasone implant is non-inferior to systemic steroids. And in many cases, it is a boon, because systemic steroids come with their own set of complications this particular group has several comorbidities, and we don't want to enhance those. So this is the second publication that we managed to get out with a French group. And this was just a retrospective study of all eyes treated with the dexamethasone implant and who had intermediate or posterior uveitis. Now, this complex graph, I'll just quickly sum up. What it shows is that there is an initial improvement in vision if you inject Ozurdex for all of these patients, followed by a drop, which would correspond to the point in time when these patients develop cataracts. And then the vision goes back again once they receive uneventful cataract surgery. And in most cases, as we know, cataract surgery has been largely perfected. And more often than not, you end up with very good outcomes. Now, the other problem with the use of dexamethasone implant that often, many people have reluctance to use it is high IOP. And what this graph shows us is that we have divided patients based upon their either presence or absence of glaucoma. So there was either no risk or no glaucoma. And if you see, only 9.4% of patients manifested an IOP spike. With prior history of glaucoma or ocular hypertension, about 16% manifest an IOP spike with Ozurdex. Patients on monotherapy or history of filtering surgery, it is more or less the same. And the same goes for patients on maximal topical therapy. So overall, the risk of IOP rise with dexamethasone is not very high. And, it's not just about the dexamethasone implant. There are other local steroid options. We live in a country which, has to finance its own therapy, and not everybody can afford the implant. So triamcinolone acetonide also seems to work equally well, provided it is used correctly. So this is just, an elaboration of our technique of injecting posterior subtenon triamcinolone. So what we do is we actually go in, incise the conjunctiva and the tenons and inject with a visco cannula, so that number one, that you're in the right plane, and number two, there is very little chance of perforation or intraoperative complications. Now, we prefer this method based upon our publication, which I'll come to shortly. And this is just a video of how to inject Ozurdex with cataract surgery. So what is important is to have a well-formed globe, and Viscoat or any visco dispersive works better. You generally remove the viscodispersive after injecting Ozurdex to avoid hypotony. Now, based upon our publication, what we have seen is that the closer the implant or the steroid molecule is to the anterior chamber or the pars ciliara, the higher the chances of IOP spike. And correspondingly, if you inject the posterior subtenon, there's a very low chance that you'll end up with an IOP spike. So even for the Ozurdex implant, the further away it is from the pars ciliara, the lesser the chances of IOP spike, among other indications, of course. And one way to achieve it is to direct it, as we saw in the video, direct it posteriorly towards the optic nerve to achieve maximal distance between the two. So here you can see this patient manifest an IOP spike within 3 days of injection. And what we see here is that it is flush with the ciliary process. So this facilitates the entry of the steroid molecule in the anterior chamber and causes trabecular meshwork alterations, which lead to IOP rise. One other problem with Ozurdex is that people are often scared to go in with such a big needle. It's a 22 gauge needle, which is higher than our which is thicker than our 23 gauge sclerotomies. So in this case, what we saw is that this is not a worm. This is the entire Ozurdex implant under the conjunctiva. So somebody just penetrated the conjunctiva and left it there. So, there are many issues associated with Ozurdex, but overall, topical therapy is a very good alternative to systemic steroids. It can be supplemented with systemic steroids at any point in time. It lessens the incidence of post-op complication. And of course, we have cheaper Ozurdex, alternatives to the intravitreal dexamethasone implant, such as triamcinolone. So thank you very much for your attention.